Hi, today I will be talking about orthostatic hypotension, which is defined as decrease in systolic blood pressure of greater than 20 mmHg or diastolic blood pressure greater than 10 mmHg within 3 minutes of standing from a supine position. Orthostatic hypotension is associated with significant morbidity and mortality. There is increased risk for falls, syncope. Syncope is the most common comorbid condition associated with orthostatic hypotension. Orthostatic hypotension is present in about 25% of the patients presenting with syncope to the emergency department. The prevalence of orthostatic hypotension in general population is around 5%, and that increases with age to around 20% for elderly people greater than 65 years. The prevalence of orthostatic hypotension is greater than 50% in geriatric patients admitted to the nursing home. Checking orthostatic vitals is the most common way to diagnose orthostatic hypotension. A bedside simplified Shalong test should be done for the diagnosis of orthostatic hypotension, which consists of measuring blood pressure and heart rate after resting in supine position for 5 minutes and then standing up for 3 minutes. Orthostatic hypotension is further classified into neurogenic and non-neurogenic. If the change in heart rate is less than 0.5 beats per 1 mmHg decrease in blood pressure, that is due to neurogenic causes. If there is a change of heart rate by greater than 0.5 beats per 1 mmHg decrease in blood pressure, that is attributed to non-neurogenic causes. Some of the common neurogenic causes include spinal cord injury, traumatic brain injury, neurodegenerative disorders secondary to Parkinson's disease, Lewy body dementia, peripheral autonomic disorders secondary to diabetes, and amyloidosis. Non-neurogenic causes are from endocrine due to adrenal insufficiency, diabetes, hypothyroidism, alcohol intoxication, metabolic such as vitamin B12 deficiency, blood loss due to trauma, anemia, cardiovascular causes such as arrhythmias, congestive heart failure. Patients with neurogenic orthostatic hypotension often have associated supine hypertension. Supine hypertension is defined as systolic blood pressure of 140 mmHg or higher and diastolic blood pressure of 90 mmHg or higher after 5 minutes in the supine position. Supine hypertension can cause nocturnal diuresis, which can in turn worsen the daytime orthostatic hypotension. Medications attributable to orthostatic hypotension include alpha-1 blockers such as tamsulosin, nitrates, tricyclic antidepressants, beta blockers, anticholinergics, loop diuretics such as furosemide, sedatives such as trazodone, centrally acting alpha-2 agonists such as clonidine, antihypertensives that are neutral or protective effect on orthostatic hypotension include calcium channel blocker, angiotensin converting enzyme inhibitors, angiotensin receptor blockers. Thiazide diuretics such as chlorthalidone has less effect on orthostatic blood pressure. Pathophysiology for orthostatic hypotension. Approximately 500 to 1000 ml of blood pools in the splanchnic circulation and in the lower extremities when a patient stands up from resting position. This in turn can decrease venous return of blood to the heart, causing decreased cardiac output and decreased in blood pressure. As a result of this, carotid sinus baroreceptors increase the sympathetic tone, decrease the parasympathetic tone, which in turn leads to increase in systemic vascular resistance and blood pressure and heart rate. Orthostatic hypotension results from insufficient or weak baroreceptor response to drop in blood pressure. It can also result from depletion of intravascular volume or medications disrupting the sympathetic system. Cerebral blood flow is maintained over a wide range of systemic blood pressure because of autoregulation. Orthostatic hypotension occurs when the blood pressure falls below the threshold needed to maintain adequate cerebral blood flow. Symptoms of orthostatic hypotension include lightheadedness, dizziness, syncope, chest pain, palpitations, dyspnea, blurred vision, nausea, vomiting, neck and shoulder pain. If clinical suspicion for orthostatic hypotension is high, in spite of negative orthostatic vitals, one should perform head-up tilt-table testing. Tilt-table testing can also be performed for assessment of chronic orthostatic intolerance such as postural orthostatic tachycardia syndrome, unexplained loss of consciousness. For this procedure, patients should have an empty bladder and be secured to a tilt table using straps. Supine position should be maintained for at least 10 minutes. Continuous non-invasive blood pressure and heart rate should be monitored. From a horizontal plane, the patient is slowly tilted upright towards 60 to 80 degrees. For detecting orthostatic hypotension, the typical duration is 5 minutes. The test should be terminated when diagnostic criteria are achieved. Postural orthostatic tachycardia syndrome is a different entity wherein the symptoms occur with upright position and are relieved with supine position. Symptoms include lightheadedness, dizziness, palpitations, fatigue, weakness. There is an increase in heart rate of greater than 30 beats per minute within 10 minutes of standing from supine position. Typically, the heart rate is greater than 120 beats per minute. Symptoms are usually worse in the morning. There's absence of orthostatic hypotension. Orthostatic intolerance makes it difficult to remain in an upright posture, which significantly affects the quality of life. Initial testing for patients with orthostatic hypotension includes basic metabolic panel to evaluate for electrolyte abnormality, complete blood count to evaluate for anemia, vitamin B12 level to evaluate for B12 deficiency, TSH, T4 to evaluate for hypothyroidism, AM cortisol level to evaluate for adrenal insufficiency, hemoglobin A1C to evaluate for diabetes, EKG to evaluate for arrhythmia, echocardiogram to evaluate for heart failure and ejection fraction, urine drug screen to evaluate for substance abuse. Management of orthostatic hypotension. Treatment should aim at reducing the symptoms rather than normalizing the blood pressure. One should discontinue the causative medications. Non-pharmacological measures include abdominal binder, which reduces the venous pooling in the splanchnic circulation, waist-high compression stockings which reduce the venous pooling in the lower extremities, elevating the bed to 30 to 45 degrees, avoid bed rest in hospitalized patients. One has to rule out postprandial hypotension, which is decreased in blood pressure within 30 minutes after having a high carbohydrate meal. Pharmacological management of orthostatic hypotension. Midodrine, which is an alpha-1 adrenergic agonist, which increases peripheral vascular resistance. Dosing 2.5 to 10 milligrams up to 3 times a day. Side effects include supine hypertension, urinary retention. It has to be avoided in patients with heart failure. Droxidopa, which is a prodrug and metabolized to norepinephrine. Dosing 100 to 600 milligrams 3 times a day. Side effects include supine hypertension. Both midodrine and droxidopa are FDA approved for management of orthostatic hypotension. Both of these medications should be avoided 3 to 4 hours before bedtime to prevent supine hypertension. Pseudostigmine, which is an acetylcholinesterase inhibitor, dosing 30 to 60 milligrams 2 to 3 times per day. Common side effects include GI cramps and diarrhea. Atomoxetine, which is a norepinephrine reuptake inhibitor, dosing 10 to 40 milligrams twice a day. Side effects include supine hypertension, headache. Fludrocortisone, which is off-label use for orthostatic hypotension, dosing 0.1 milligram per day, titrate up to 0.2 milligrams. Use caution in patients with heart failure. Finally, hypertension is the most common condition associated with orthostatic hypotension, and its presence complicates the management of both conditions. It's a common practice to hold antihypertensive medications in patients presenting with orthostatic hypotension. However, this approach can have a paradoxical effect, resulting in supine hypertension, which in turn worsens orthostatic hypotension.